Hey everybody, welcome back to the ECG channel. My name is Reed and we have an exciting lecture today about myocardial ischemia and infarctions. We're going to talk about ST segment elevation, ST segment depression, the anatomy associated with those in each of the leads so that we can determine where that ST depression or elevation is representing within the myocardium. So stay tuned. By the end of this lecture, you're going to be able to take a look at ECGs just like this one and say with good certainty what's going on and what needs to happen next. So, but before we get into that, we need to go back to the basics. We're going to talk first about coronary artery anatomy. We're going to understand why that anatomy is important in terms of ischemic events, the pathophysiology of ischemia and infarction, and then how the ECG actually records that signal of ischemia and infarction and transmit that to what we see here in front of us. So really going down to the basics, dialing in the physiology behind is going to help you have a great foundation so that whenever you see these in the real world, you can, treat them and do a great job. So let's jump into it. So first we're going to go to this diagram and we're going to talk about coronary artery anatomy. We're going to then correlate that coronary artery anatomy to the ECG itself. So we're going to start with the aorta. The aorta sits right here. This is the aorta. And the aorta is the main vessel that supplies or perfuses the entire periphery, right? So the left ventricle takes that oxygenated blood that just returned back from the pulmonary vessels, sends it off to your body. But it also needs to supply itself. So the heart is one of the interesting organs that it actually supplies its own oxygen, right? So the aorta, just past the aortic valve, which we'll draw the aortic valve is kind of right, you can get some x-ray vision, it's right there. The aortic valve, just past it, is where our vessels, the branches of the coronary arteries originate, right? And so the first one we're going to talk about is this branch right here. You can see it kind of running just under, this is the pulmonary artery coming off the RV. And that first branch is the left main coronary artery, right? And the left main coronary artery is going to give off branches pretty quickly. There's two of them that you see. The first branch we're going to talk about is the left anterior descending artery, right? Or sometimes we see it labeled as the LAD, right? So the left anterior descending artery, or the LAD, is the first branch that dives anteriorly over the myocardium, right? We're looking right at the myocardium in anatomical position. In the left anterior descending, it runs down this groove, and that groove is in between the left ventricle and the right ventricle. So other terminology, more we'll say accurate terminology for the left anterior descending artery is actually the anterior interventricular branch of the left coronary artery, right? It's the interventricular branch because it runs in between the two ventricles in this little kind of groove that's created, right? And as you can tell, it's going to supply mostly the anterior portion of the myocardium. But let's talk a little bit more specifically. So first thing it's going to give off is it's going to give off branches. It's going to give off branches pretty early, and those branches supply the septum. So these are septal perforators. So it supplies the septum. Remember, the septum is that bit of muscle between the left ventricle and the right ventricle. So it gives off septal perforators. It also gives off other vessels that really continues to supply a bulk of the anterolateral myocardium. And these are called diagonals. So diagonal branches, right? So we've got septal perforators, we've got diagonals. And as you notice, let's talk about what anatomical region of the myocardium does the left anterior descending perfuse. Well, we get the anterior and lateral left ventricle, right? Mostly the left ventricle because that's, it's going in between that groove and they're all branching to the left. So LAD is the anterior and lateral myocardium. Another phrase you might hear about the LAD is the widowmaker. It's because it's kind of a really negative term, I suppose, but when you have a heart attack, that's really an occlusion of the LAD. They call it a widowmaker. So the next branch that we're going to talk about off of the left main coronary artery is the left circumflex. So here is the next branch. In this branch, we're going to draw it up here, is the left circumflex. Sometimes you see it LCX, right? Big L, big C, little x, left circumflex. The left circumflex really travels along the ridge between the left atrium and the left ventricle, right? Sometimes they call this the left coronary sulcus, right? So sometimes they call this the left coronary sulcus, and that's where it runs. So obviously, it's going to have branches that supply the left atrium. So it's going to supply the left atrium. Also, what it does is it's going to wrap around laterally and a little bit posteriorly. My dotted lines are going to represent kind of like x-ray vision, like we can see through the heart. It's going to wrap around a little bit posteriorly, and it's going to supply the lateral and posterior left ventricle, right? So left circumflex is going to supply the lateral and posterior left ventricle. It gives off branches, and its branches that it gives off are called marginals. So the branches, they're termed marginals. So we said that it also supplies the posterior left ventricle. And what is interesting is that in 20% of people in the world, the left circumflex continues to extend posteriorly, and it connects to, we'll do this in black right here, it connects to the PDA, or the posterior descending artery, right? So that's the posterior descending artery. The posterior descending artery runs, if you had see-through x-ray vision, this is my dotted line example again, the posterior descending artery runs down the posterior interventricular groove. So sometimes the PDA, which we all have PDAs, they call it the posterior interventricular artery. So in 20% of the cases, we see that the left circumflex is the main supply to that posterior descending artery, right? And in the 20% of people that have that connection between those two vessels, they are called left dominant, right? And I'll explain what the other opposite of that, right dominant, is in a second, but those are left dominant hearts. So if you ever hear that, that's because the left circumflex wraps around the ventricular myocardium and actually has a really strong connection between the posterior descending and supplies that vessel, right? This is going to matter on our EKGs, obviously. If we have left circumflex occlusion, we can determine is there posterior involvement or not. We can determine if this patient is maybe posterior dominant or left dominant or not. So that's the left circumflex. And now we're going to transition to the right coronary artery. So the right coronary artery, you see it branches off the aorta on the right side. And so let's talk about the right coronary, and this is labeled RCA. So if I call it RCA, that's what we're talking about. And the right coronary artery runs, it's almost the opposite of the left circumflex. It runs in this groove between, you guessed, the right atrium and the right ventricle. And so sometimes we call this it running through the right coronary sulcus, right? Just like the left circumflex is the left coronary sulcus, this is the right coronary sulcus. In what region of the myocardium does the right coronary artery supply? Well, you can see here it gives off branches to the right atrium, so it supplies the right atrium. It also, interestingly, before we talk about where it else supplies, it also supplies our SA and our AV nodes. So it gives off branches that go to the SA node, and it gives off branches that go to the AV node. Those are the SA and AV nodal arteries. So kind of giving you a little bit of a heads up, if you get a right coronary artery occlusion that is proximal to those vessels, those branches, you might see SA or AV node dysfunction, right? So this is all for a reason. So it gives off branches to the SA and AV nodes, and then it's going to continue, and it's going to give off more branches that supply the inferior myocardium. So it's got a lot of inferior vessels, right? As we see it wrapped towards the bottom of the heart, right? Left side is kind of more anterior. These are a little bit more inferior. And if I had x-ray vision, you would see that the right coronary can go posterior, and in 80% of people supply the posterior descending artery, okay? So in 80% of cases, the right coronary artery is the main blood supply to that posterior descending. So that would be a right dominant. This patient would be right dominant. So big aspects or big regions that we see with the right coronary artery. We've got right atrium. We've also obviously got the inferior myocardium, supplies most of all of the right ventricle, and it actually does supply a little bit of the posterior aspect of the interventricular septum, right? So it actually kind of can give off little branches here that supply the posterior aspect of the interventricular septum, right? LAD supplies anterior, right coronary artery is a little bit more of that posterior aspect of the interventricular septum. And before we kind of go into the EKG representation of these vessels itself, let's briefly talk about how these vessels are oriented. You notice here I'm looking at the surface of the heart, and you see these vessels are running in the surface of the heart. Usually we think of most organs, the vessels penetrate the middle of that organ and then branch to the periphery, right? Like a kidney, if I drew a kidney right here, and I had my renal artery coming in, we'll do it in red. I got my renal artery coming in. Usually it has branches from the inside to the surface, right? It branches inside the surface. Notice here it's going from the epicardium to the endocardium. We need to talk about why that's important, because we need to understand what part of the myocardium is going to be damaged first when there is vascular compromise, because we know myocardial ischemia and infarctions are vascular events. So if I took this heart and I did a slice, transverse slice right through the heart, so say I drew this slice, right? I'm going to do like a three-dimensional slice here, try to see what I can do, but I slice the heart just like this, three-dimensional. I cut through it, I would get this. And so this is a representation of that. And let's move my pen over here. And so you see we've got it labeled anterior, right, left, and posterior because we're in anatomical position. And so those vessels that we were just talking about, they run on the epicardial aspect of the heart, right? So these vessels, these are the vessels, they run in the epicardium, right? And then they dive in. So then they send branches in, right? They've got branches that come in, right? This is, in fact, if you look at this one, this is my left anterior descending. Remember I said the left anterior descending runs anterior and inferior along that groove between the left ventricle and the right ventricle. So that's my LAD. And this is my posterior descending artery doing the exact same but on the posterior side of the heart in between the right and left ventricles. So that's actually a good depiction of those vessels. And let's just briefly talk about why they're located on the outside and they give blood flow from the epicardium to the endocardium. And the reason is because when the heart contracts, remember the heart has to supply its own blood or oxygen. When the heart contracts, the pressure builds up really, really high within the left and right ventricles themselves, right? And so the pressure is so high that any blood coming from the inside that would be perfusing the heart from the inside, it wouldn't be able to get there because there's no gradient. So actually what happens is these epicardial vessels, when the heart squeezes and contracts, they can't push blood flow into the deepest layers of the myocardium to supply it because it's so tight, so high pressurized. But when that muscle relaxes in diastole, we see that blood supply or perfusion of the heart happens in diastole, right? Because those vessels open up, we have a good pressure gradient for the blood to exit and run down the pressure gradient. So it's important because now we're understanding that perfusion of the ventricular myocardium goes from the epicardium to the endocardium, right? So perfusion is from epicardium first to endocardium. that's really important because if we have a vascular event, vascular narrowing, the epicardium is going to be, it's going to be more preserved. The endocardium, this layer deep down here, is going to be at a higher likelihood of being injured or damaged. And so we need to take that into account whenever we're thinking of kind of what aspect of the ventricle is being malperfused. And so let's talk a little bit about a vascular event. And so we'll start to draw and understand this idea. And so say I've got this vessel, right? If I just take a vessel out of the heart, and it's going to, this is branching off as it's traveling into that myocardium, right? So this is kind of this is a little bit more of that deep layer of the myocardium. This is more superficial. And so we got blood flow that is running down this vessel, right? So what happens in myocardial ischemia and infarction, what precedes it is a chronic event called atherosclerosis, right? Where we've got somebody's got high blood sugar chronically, they've got high cholesterol chronically, and you end up getting these collections. Those collections, it's this chronic inflammatory condition called atherosclerosis, and they notice the lumen of that vessel is starting to narrow. So the lumen of the vessel is starting to narrow. And so the blood, as it's trying to go through, it's going to have a harder time going through that pipe, right? As the lumen is narrowing. The lumen is just the inside of that vessel, right? So over time, it gets narrow, more and more narrow, right? And so as this happens, usually nothing happens until we get to at least 70% stenosis. So if somebody's got luminal narrowing, we're not going to see symptoms or signs of that until it gets to at least 70% stenosed, right? But what ends up happening is as that vessel gets tighter and tighter and tighter, less blood is able to flow through. It's a lot more difficult. And once it gets past that 70%, you might experience something called angina, right? So there might be something first that you experience called angina. Okay, and angina is when somebody's exerting themselves, right? Their heart has to pump faster, harder, and also, essentially, we're going to increase the demand. So angina, we're increasing demand on the heart, and we're unable to supply. So there's less supply, right? Because of that stenosis, right? And so whenever I'm out, mowing the grass, running, walking, I start getting this chest pain or pressure, and that's called angina. So that's the first physical sign that we have stenosis of a coronary artery, right? Because your body is able to perceive the pain produced by a lack of supply, a worsening of a supply demand. So that's angina. And over time, it'll continue to narrow. So here I'm drawing, it's narrow, it's really, really, really narrow. Right, remember angina, it's just a demand thing. So when the demand gets too high, you feel that feeling. So when you rest and you decrease that demand, the supply-demand ratio gets better. But over time, as that vessel gets more and more and more narrow, you get something called unstable angina. An unstable angina is now you have at rest, there is no increase in the demand of the heart. It's just beating at rest, but you are unable to give enough supply because it is so stenosed that even just when you're resting and your heart is beating at rest, you cannot supply it with enough blood or oxygen. And that's unstable angina. And then what can happen is it can get so stenosed, it can get even more stenosed, that it is unable to supply the deepest layers of the myocardium. So say I zoom in on this vessel here, and I've got my penetrating vessel, and it's got stenosis, right? And it gets so stenosed that when the blood is trying to flow through, it is so limited that the blood flow can't reach the deepest part of the myocardium. And so you end up getting damage to that myocardium. At the deepest layers, that in blue is representing a portion of the myocardium that is ischemia or ischemic. And if that vessel gets so narrow, it can become infarcted. When that happens, that subendocardium, we call that the subendocardium. That's the subendocardium. When that happens, we get subendocardial ischemia. That is, you can sometimes have an MI. And so oftentimes you'll see subendocardial ischemia represented by a non-ST segment elevation myocardial infarction, or an NSTEMI, right? Because it doesn't produce ST segment elevation in the subendocardial ischemia. It just doesn't. And we're going to talk about that mechanism here in a second. So subendocardial ischemia, why is it called a subendocardium and not the endocardium? Well, the endocardium, if I drew my endocardium right here, the endocardium, interestingly, receives blood supply from the blood that's actually in the lumen of the left ventricle. So the endocardium itself is well preserved in these coronary artery events. But the subendocardium is the first layer to go, right? When we get such narrowing of the blood vessels, right? And then the last thing that can happen, the worst thing, and it's going to be a big topic of today's lecture, is that vessel, to say there's an acute event where we get acute inflammation and we get blood clot formation. And so we get a blood clot. And now that stenosis is 100% occluded. That, if you look at this vessel here, if that occurred where you have a occlusion, that's my occlusion, now there is no blood that is able to enter, right? This is all the blood here in this lumen. It's unable to enter. It can't enter. And so we get something called transmural ischemia or infarction, where the entire wall, transmural infarction, right? So that, we'll write it over here, is transmural ischemia, transmural infarction. And that is what produces our ST segment elevation myocardial infarction, or STEMI, okay? So that's the anatomy. That's the region of the myocardium that gets injured. We're going to talk a little bit about how that is represented on the EKG. Depolarization occurs from the fascicles, right? These are the Purkinje fibers that are transmitting signal to the endocardium and is depolarizing from endocardium to epicardium, creating our QRS complex. And then we have repolarization that occurs in the opposite direction from epicardium to endocardium. And what that does is that creates our T wave. And remembering why the QRS and T wave are in the same direction, even though these electrical events are opposite, is important. So remember that in a normal cell, here's our cell, depolarization is sodium rushing into that cell. Repolarization is potassium rushing out of the cell, right? Two different electrical events, right? One of is positive charge going in, so sodium going in. The other one is potassium coming out, and they're happening in different directions from each other, creating opposite, but double opposites. So you get a QRS and a T wave that is generally in the same direction, right? This is important. We're setting ourselves up to understand why the ST segment is implicated kind of in this ischemic infarction stuff. So the ST segment, which is from the end of the QRS to the beginning of the T wave, this is our ST segment. And notice that the ST segment is isoelectric. Let's talk about a little bit why that is, and then how we can expect it to change as aspects of the myocardium also change with ischemia. So first thing we're going to do is we're going to overlay the action potential, right? So here's an action potential. We've got depolarization, and then we have repolarization, right? That's our cellular action potential, right? So repolarization creates this QRS complex, and then our repolarization wave still creates the T wave, right, or repolarizing. In our segments here, we've got phase 0, we've got phase 1, phase 2 is that big flat part, Phase 3 is repolarization, and then phase 4 is our return to baseline. And so notice that the isoelectric aspect of phase 2 correlates with the isoelectric aspect of our ST segment, right? Remember, phase 2 is defined cellularly. In phase 2, we've got calcium, which is positive, rushing in, and we have this potassium continuing to rush out. And so those are equal, positive coming in, positive coming out, and so you get an isoelectric flat line in the action potential, which causes a flat line in our ST segment. So that's kind of how we define our ST segment anatomically and electrophysiologically, right? So what happens when a region becomes ischemic? Well, ischemic tissue, we'll say ischemic myocardium, there's this interesting phenomenon where when the cell membrane gets ischemic, it gets inflamed, it gets angry, there's an increase in the extracellular potassium, right? Why does that matter? This is an important concept. So there's more potassium. If I look at my cell again, there's more potassium that's now outside of the cell. And remember that the action potential, if we look at it from an X and Y axis standpoint, remember the Y axis is our membrane, our transmembrane potential, right? Where we essentially are measuring the difference between inside of the cell and outside of the cell. So if we have more positive things outside of the cell, it's going to decrease that transmembrane potential. And so in cells that are ischemic, you get this phenomenon where you have more extracellular potassium. And because potassium is so implicated in phase 2, that homeostatic flatline of phase 2, you get a change in that. And so you get in ischemic tissues, I'll draw this in blue. In ischemic tissues, you get a new shape of your action potential where phase 2 is lower, right? And so notice the difference between the healthy cells' action potential and the ischemic cells' action potential. It's really the difference in that phase 2, okay? And so what ends up happening is it creates a voltage gradient between the healthy and the ischemic tissue, and you end up getting a voltage gradient towards that ischemic tissue. So that's our voltage gradient. Okay? And so when you get a voltage gradient in phase 2, usually there is no voltage gradient, but we get one in phase 2, you get changes to your ST segments. So let's talk about what happens first if you have, we'll talk about first subendocardial ischemia, right? Subendocardial ischemia occurs when an epicardial vessel, we're just going to draw one right here, that's got its branches that supply the deep region of the myocardium. It gets so narrowed, right, here's our atherosclerosis, that blood really just can't squeeze through it effectively. It just can't really make it. So what happens is that subendocardium, which I'm going to draw here in blue, the subendocardium gets ischemic, right? It's a subendocardial infarction or ischemic event. And so that is the region that has this ischemic increase in extracellular potassium, right? It changes phase 2. And so what are we going to see in the leads that are measuring this region? Well, we're going to see now in phase 2 a voltage gradient going from the healthy cells towards the ischemic cells, right? Remember we said it's going from the healthy to the ischemic. Our healthy cells are here in the epicardium, so we get a voltage gradient during phase 2, which is producing the ST segment, towards the subendocardium. And remember our leads, if this is like a lead right here, our leads are now measuring the lead in this area, our EKG lead, is measuring these forces that are headed away from it during phase 2. And so what do you get? You get ST segment depression, right? So you get ST depression, right? So in subendocardial ischemia, you get ST segment depression. Our ST segments, we have our baseline here in yellow, and then we have our ST segment that I'll draw in red, right? We usually measure the ST segment 1 to 2 little boxes from the end of the QRS, or the J point, we would call it. So we measure it here, and so we get ST segment depression in those leads that are measuring the forces going away, right? That would be, if it's a focal subendocardial event, you might see it focally in a certain amount of leads. Imagine if you had subendocardial ischemia all the way around, everywhere was ischemic. You could get diffuse subendocardial ischemia if someone's anemic. Say, I've lost a lot of blood, I've got a GI bleed, I don't have good oxygen carrying capacity. Everything in my subendocardium can become ischemic. So you might see diffuse ST segment depressions and diffuse subendocardial ischemic physiologies, right? You could see that in like a tachyarrhythmia, right? Someone's got SVT at a rate of 200 beats per minute. You're beating so fast, you don't have enough time to be in diastole to fill, so you end up not feeling the subendocardial region enough, right? So those are just a couple examples of, one, it can be focal atherosclerotic, like we just explained with this coronary event, or it could be diffuse subendocardial ischemia, right? So the way you see that on the leads is going to matter for that. So that's what we see in subendocardial ischemia. Let's talk about what happens. We'll erase that. Let's talk about what happens in transmural ischemia, right? In transmural ischemia, if I zoom in on this epicardial vessel that's got branches that are heading into its region, right? You get, say, an occlusion here. So there's my occlusion, and so all the blood can't get to any of the entire myocardium, right? So now we get this transmural infarction or ischemic event. So transmural, and notice that I'm not saying that the endocardium is involved. The endocardium, right, is that layer that is actually supplied by oxygen from the blood that's actually in the ventricle itself. So the endocardium is actually preserved in both of these events, right? This is subendocardial, right? So we still have preserved endocardium. And here, we still have this preserved endocardium, but we've got this transmural ischemic event. Remember, if I redraw my healthy, I'll do it in red, healthy action potential cell, and then my ischemic cell with the depressed phase 2, looking something like that. Remember, you get the voltage gradients from the healthy to the ischemic in phase 2, which is during the ST segment aspect. So which areas are healthy? The endocardium is. So I'm going to say my endocardium is healthy, and I'm going to get a voltage gradient during phase 2 towards that ischemic tissue. So notice this is going from endocardial to epicardial, or are those voltage gradients, right? Those vector forces. And so if I look at my QRS complex that's produced by this event, you're going to see QRS, ST segment elevation, right? Where my baseline is here, and my ST segment measured, and it's elevated, right? This is an elevation of that ST segment. So in transmural ischemia, transmural infarctions, you're going to see ST elevation, right? And so that is the mechanism that explains the difference between subendocardial ischemia, transmural ischemia. So we think of like STEMI, ST segment elevation, ST elevation myocardial infarction. We think STEMIs are associated with transmural ischemia. Whereas we think of NSTEMIs, non-ST segment elevation myocardial infarction, are more associated with subendocardial events, right? Obviously, there is still myocardial infarction, but what region is infarcted? In STEMIs, it's transmural infarctions, and in NSTEMIs, it's subendocardial infarction, right? they're different in terms of their prognosis, obviously, and their treatments, right? In a STEMI, you can maybe go and retrieve that clot and stent it open. In a subendocardial event, there's really not a vessel that you can open up right in that moment that's going to change the outcome for the subendocardium, right? So now that we understand the changes of those ST segments, let's go back and let's talk about the leads themselves, right? Because these events have to happen in the leads that are capturing the electrical event of that aspect of the myocardium, right? So we're not just going to see this everywhere. We're only going to see it in predictable regions. Remember that we know that each region of the heart is supplied by different vessels. So let's review the anatomy of the vessels, the regions of the heart, what leads they are represented by, and then let's jump into a ton of EKG examples. Alrighty, so here we have three diagrams. We have just our coronary anatomy diagram here, diagram 1. We have our coronal view of the heart, which coronal, remember, is slicing my body this way. So coronal will represent horizontal changes in voltage and inferior, superior changes in voltage. And then you have the transverse, which is essentially cutting me right here in the chest, through the chest, in a horizontal plane, right? So that measures forces going anterior, posterior, and lateral as well along that plane that's created, okay? So let's talk about first which leads are representing each different wall or region of the myocardium, right? First, we'll talk about lateral, right? So the lateral aspect of the myocardium, if I draw it here, lateral region in green. And so let's correlate that to our leads. We see over here on the coronal view, here's lateral. And so the leads that are going to pick up forces going towards the lateral aspect are going to be leads 1, leads AVL. So lateral, we've got 1 AVL. And if you look on our transverse plane, here's the lateral aspect of the myocardium. So the leads that are picking up forces heading in that direction are V5 and V6. So our lateral leads are 1 AVL, V5, V6. Alrighty. Let's move towards the anterior, right? So we have our anterior region. The anterior region, I'll draw it in red right here. This aspect of the myocardium is our anterior myocardium. And if you notice the coronal, we don't get anterior forces red on the coronal leads, but we do in the transverse plane. So if I zoom in on the transverse plane, here's my anterior myocardium. So the forces that are heading towards the anterior myocardium are getting picked up by leads V3 and V4. So anterior is V3, V4, okay? The next region that we're gonna talk about is the inferior aspect of the myocardium. The transverse plane doesn't pick up any of those inferior signals, but the coronal plane does. And so here in, say, blue is our inferior aspect of the myocardium, right? It's also over here. I'll do it in blue over here too. So it's inferior. You see in our coronal plane, we also have our inferior. And look at the leads that are picking up those signals, right? Leads 2, leads 3, leads AVF. So the inferior leads are predominantly leads 2, leads 3, and leads AVF. And then the last region is the septum. So the septum, or the septal leads, are, if I zoom in on the transverse, remember that the septum, this is kind of a fun little reminder, remember that the septum, the interventricular septum, the depolarization of that little portion of muscle is supplied by the left bundle. So if the left bundle supplies the forces to the interventricular septum, you get a wave of depolarization going from left to right, just a little wave. But look what leads are picking that up, lead V1 and V2. So V1 and V2 are our septal leads, okay? So when we say we have a lateral, the lateral leads have ST segment changes. Those are 1 AVL, V5, V6, anterior, inferior, septal, all are those regions, right? So when we think about our coronary artery anatomy, let's think about what happens if we have right coronary artery. If my right coronary artery is going to be represented by a lead, what lead is it going to be represented by? Well, we know the right coronary artery is going to come down. It's going to supply the inferior myocardium, which is leads 2, 3, and AVF. And we said that 80% of the time, that right coronary is going to wrap around, and if I had X-ray vision, is going to also supply the posterior descending, so it's also going to see the posterior aspect of the myocardium. So the right coronary, we're also going to get posterior 80% of the time, but I didn't tell you that there's a posterior lead. There's not, right? The back of us don't have leads on us, right? But if we look at our transverse plane, this is what's interesting. The posterior myocardium, if I was going to draw it in black, would be right here. So force is heading towards the posterior myocardium is heading posteriorly. We don't have a lead that is back there. But what we do have are leads, such as leads V2 and V3, that are recording opposite or reciprocal changes to the posterior myocardium. So the posterior myocardium is actually represented reciprocally by leads V2 and V3. Okay, so some right coronary artery stuff, we're thinking those leads. Let's talk about left anterior descending, right? We said that the left anterior descending branches off the left coronary artery and heads down anteriorly and laterally, but also supplies the septum. So we're going to see, if it's proximal to the septal leads, we're going to see V1 and V2 for the septal representation. We're going to see anterior, which is going to be V3 and V4. And you might get some lateral involvement, right? 1, AVL, V5, and V6 if it's a big enough LAD occlusion, right? The last vessel is going to be our left circumflex. I'm going to draw this one right here, left circumflex. And the left circumflex, remember, branches off of the left main coronary artery. And it wraps around to this high lateral region, right? So it's going to be kind of, this region is going to be really supplied. So really the high lateral leads, which if we look here, we've got lead 1 and AVL that are really kind of on the high lateral. So we would call those high lateral leads. So left circumflex, you're going to see definitely 1 in AVL most of the time. And in 20% of the cases, in a left dominant heart, we're also going to see the posterior V2 and V3 reciprocal changes, right? So left circumflex, you're just going to get kind of lateral, and in 20% of the cases, posterolateral, right? So it gets a little tricky, a little bit nuanced, but we're just going to stay kind of surface level broad here, right? So it's a lot. What does that look like on the EKG? So I have this fun diagram that I made, and this shows the regions of the myocardium on an EKG. So you see leads 2, 3, and AVF are inferior. We've got 1 and AVL are high lateral. V3, V4 anterior, 5 and 6, V5, V6 are the lateral, and we've got our septal leads in V1 and V2. And so that's an important thing to understand, because when we have these ST segment changes, they're going to be in predictable regions, right? And so that brings me to this idea that ST segment changes, there's this concept of contiguous, C-O-N-T-I-G-U-O-U-S, contiguous. And contiguous means that the leads are contiguous with each other. So a contiguous set of leads would be leads 2, 3, and AVF. These are contiguous with each other. They are representing adjacent regions, right? Another contiguous region would be 1 in AVL, the high lateral, V5 and V6, the anterior, V3 and V4, and the septal, V1 and V2. That is contiguous, meaning they're kind of continuous with each other. And so when I see ST segment either elevation or depression, I need to see that in at least 2 contiguous leads. So that tells me that if this is truly a coronary artery event, I should see them in at least 2 adjacent leads, right? So if I see ST segment elevation in lead 3, I should also see it in lead 2 or in lead AVF to say this is a coronary artery event, right? So we're going to want to see as ST segment changes. If it's a focal occlusion, right, either a focal NSTEMI or a focal STEMI, we're going to see that, right? So we're going to say focal, right? So that's the first thing we want to talk about. And the second thing we're going to talk about, I'm just going to talk about this briefly, is this idea again of reciprocal changes, right? Reciprocal changes is essentially saying if I'm recording a focal event in these leads, the opposite leads should be recording that focal event, but reverse, inverse, reciprocal, right? So what I mean by that is if I have an ST segment elevation, say if I zoom in on this coronal view, if I have ST segment elevation in leads 1 and AVL, there's my ST segment elevation. That's a really bad drawing. Let's do that again. ST segment elevation, right? Notice my ST segment here is elevated. I should see ST segment depression in the opposite leads, maybe over here in the inferior leads, leads 3, where I see ST depression, right? That's my ST depression. And that's because forces that are heading towards 1 and AVL are heading away from these inferior leads. So I should see a predictable change, and I could say, put my finger on it, the anatomy makes sense, right? So reciprocal changes, you're going to look for those. Not everything has a reciprocal change, because not every lead has a perfect reciprocal lead, right? But some of them do. So those are reciprocal changes. So with that being said, we've now gone over the coronary artery anatomy. We've gone over how those coronary arteries functionally work, going from epicardium to endocardium. We talked about depolarization, repolarization in the ST segment, and we've also talked about how that ST segment will predictably change either with focal ischemia or full subendocardial ischemia. So let's jump into some EKGs and see what we can do. So the first EKG here, this is an example of what I would call rate-related ischemia, right? So this is an example, before we get into the big STEMIs, because the rest of these are going to be STEMIs, this is rate-related ischemia, right? This EKG is 2-to-1 atrial flutter, and the rate of this EKG is super fast, right? It's really fast. The rate is over 150 beats per minute. Remember I said that if you have such a fast beating heart, you sometimes can't get blood in diastole to get all the way from epicardium to endocardium. So you could see in rate-related ischemia, diffuse subendocardial ischemia. Right? So we have diffuse subendocardial ischemia. So what you're going to see is you're going to see non-focal ST segment changes. So just briefly, before we jump into all the STEMIs, which is what we're all here for, take a look. We see our baseline, and then you see your ST segment, right? You've got baseline, then you got your ST segment, right? And so that, if you look throughout all the leads, you might see diffuse ST segment depression, right? And so when you see that here, this is a non-specific, a non-localizing ST segment depression. Oftentimes when you slow these rhythms down, right, if it's a flutter, you give them a calcium channel blocker, a beta blocker, or you cardiovert them, or whatever you end up doing, you slow it down, that supply and demand mismatch resolves, right? And that diffuse subendocardial ischemia from that tachyarrhythmia resolves, right? Remember, we also said you can see diffuse subendocardial ischemia in people with severe anemia, right? The difference is that in anemia, they're going to be in sinus tachycardia because they're trying to get oxygen everywhere and they can't because they don't have enough oxygen carrying capacity because they don't have all the red blood cells that they need. So that's just one example of a rate-related ischemia. Let's jump into the fun stuff. So first EKG here, we're not going to go through the full approach for all these EKGs. We've got a bunch. But what you'll notice is it's a sinus rhythm. You've got P waves that are going to the QRSs. And when I look for my ischemia or infarction, I see ST segment elevation in the following leads. If I zoom in, I see my baseline here, and I notice that I've got ST segment elevation in leads 2, in leads 3, in leads AVF. So let's go to our chart. We've got ST segment elevation in leads 2, 3, and AVF. So inferior leads have ST segment elevation, right? So far, our ST segments are elevated in the inferior leads. And if I keep scanning through, I see ST segment depression in lead V2. So I have ST depression in V2, which, if I go down here, ST segment depression in V2, remember we said that sometimes posterior involvement of a myocardial infarction would produce, oops, I just dropped my pen, would produce ST segment changes in the opposite direction in V2. So maybe I've got posterior involvement. So far I'm seeing inferior and posterior involvement in this myocardial infarction. And so what might we think is the cause of a region of inferior and posterior myocardial infarction? Well, remember, the right coronary artery supplies inferior as well as, in 80% of the time, posterior myocardium via the posterior descending artery. So you might think this is a right coronary artery infarction where we're getting inferior posterior signs. Well, the last thing we can do is we can look for reciprocal changes. So we need to look for reciprocal change. And I know that if I have ST segment elevation in my inferior leads, I should look opposite of those for ST segment depression in AVL. And a little bit to a lesser degree in lead 1, because AVL is better aligned with these inferior leads. And so if I look closely, I see that AVL, so my baseline, has ST segment depression, and to a lesser degree, ST segment depression in lead 1. So I have ST depression in the high lateral leads. Those are reciprocal changes. That's reciprocal ST segment depression. So here I have ST segment elevation in the inferior and posterior regions with reciprocal changes in the high lateral leads 1 and AVL. And so this is all pointing towards my right coronary artery becoming infarcted. You might also have noticed something interesting is that we also have a first degree AV block, right? My PR interval is greater than 200 milliseconds. And so remember that the right coronary artery also supplies the SA and AV nodes. So maybe there's some AV nodal involvement that we're seeing here as well. We need to probably trend that, right? This is a good example of inferior posterior STEMI, okay? Next example, we've got, you're going to see a similar trend here. Leads 2, 3, and AVF, we've got ST segment elevation. But I want to tell you something that's a little bit different, not different, excuse me, a little bit more detail about the ST segment elevation in this EKG. So this is similar. We've got ST elevation in leads 2, 3, and AVF, which are representing the inferior myocardium, 2, 3, and AVF. Look, we've got ST depression focally in lead V2, which tells me that that might be a reciprocal change because there might actually be posterior involvement. So we're seeing the actual opposite changes. So we might see posterior involvement as well. And we see, in a similar sense, the reciprocal changes that we would expect in the high lateral leads, AVL in lead 1, right? We have reciprocal ST depression, okay? So here is another example of a right coronary artery occlusion, but let's talk a little bit more about the details here. The right coronary artery comes over to the right side and is very right-sided dominant, obviously, by its name. So when I look at the ST segment elevation in the inferior leads, I should see the most ST segment elevation in lead 3. So in RCA occlusion, this is a huge pearl, RCA occlusions, you should see ST elevation largest in lead 3, greater than, what's the next one in line? AVF, greater than, what's next in line? Lead 2, right? Because the most infarction is going to be in this region over lead 3, and then to a lesser degree it peters off to AVF in lead 2. So we see the most ST segment elevation in leads 3, AVF, and then lead 2. Similarly, the most reciprocal lead to lead 3, so we said lead 3 is going to have the most ST segment elevation. The most reciprocal lead to lead 3, the most in line with it, is AVL. So we should see in a right coronary artery infarction, the reciprocal changes the most ST depression in AVL, right? So let's take a look at this. Let's zoom in on leads 2, 3, and AVF, and let's measure. So here we've got ST segment elevation. We'll probably measure it from there, here. So let's say, I would call that 7 millimeters of ST elevation in lead 3. AVF, you've got ST segment elevation, but that's probably 6 millimeters. And then look at lead 2, you've got ST elevation, but that's like 5 millimeters. So here we've got 3 greater than AVF greater than 2, which really tells me this is right coronary artery, most likely. Similarly, we said that we would see the most ST depression reciprocally in lead AVL, and you can see that AVL's ST depression is much more significant than lead 1's, even though there still is. All just accumulating data that we can focally say the infarction is here in the inferior, right-sided, and posterior myocardium, all pointing to that right coronary artery occlusion, okay? Next EKG here is another right coronary artery occlusion. You guessed it. So the difference here between the other ones, first we see we've got ST segment elevation in lead 3, in lead 2, in lead AVF, but the order of things is lead 3 is greater than AVF is greater than lead 2 in these ST segment elevations, right? So that's right-sided. V2, you can see a little bit of that posterior ST depression. So a little bit of posterior involvement here. And you see those reciprocal changes in lead 1 in AVL, right? Reciprocal changes in lead 1, that ST depression in AVL that's higher than lead 1. So everything again is pointing towards what? So pointing towards this right coronary artery, right? The difference in this EKG is that this rhythm is very slow. If I counted the rate, I started here and I did 300, 150, 100, 75, 60, 50, 40, probably what? I'm going to say 45 beats per minute. It's a pretty slow rhythm. And when I look at the P waves, you have to find a lead that's got some P waves. You'll notice that in lead 2, there's a P wave. There's another P wave. The next P wave is probably buried in that QRS. Here's the next P wave. This is a complete third degree heart block or AV block. And so remember, oftentimes in right coronary artery occlusions, the AV node, if the occlusion is proximal to the branch that supplies the AV node, right? So say my AV nodal branch, for example, is this one. If my coronary artery occlusion is right here, well, I'm also going to cause ischemia to the AV node. And so that's why you see here this complete heart block. Sometimes you can see first degree heart blocks, you can see second degree heart blocks, like a Winky Bach phenomenon, you'll see that sometimes. So when you see right coronary artery occlusions, another thing to look for is AV blocks. This is a good example of that. Let's move on to the next EKG. Now we're going to change coronary arteries. So now we're going to look here, and we zoom in, we see the most ST segment elevation where? We see ST segment elevation V3. Here's our baseline. That's our ST segment. We see ST segment elevation in V2. We see it to a pretty good amount in V4, and then to a lesser degree in V5. And so where are we seeing the most ST segment elevation? The actual amount of ST segment elevation matters. So we see the most here, V3 and V4. So we've got V3 and V4 predominant ST segment elevation. We definitely have some in V2, and we still have a little bit in V1, but predominantly V3, V4. Remember that V3 and V4 supply what? Or record the anterior aspect of the myocardium. And what blood vessel is running via the anterior region of the myocardium? That's our left anterior descending, right? So this is anterior. This is an anterior STEMI. And it's hard to get good reciprocal changes in big anterior STEMIs, but sometimes if that anterior STEMI gets a little bit lateral, you can see some reciprocal ST segment depression in the inferior leads. So you see some ST depression here in AVF, you see ST segment depression here in lead 3, and a little bit, to a lesser degree, in lead 2, right? If you look closely, you even see some lateral involvement in this MI, a little bit of lateral involvement here, which is probably why if we have lateral involvement, if you also have anterior lateral, where you see ST elevation in lead 1 and AVL, you're going to see reciprocal depression in the inferior leads, right? So we're seeing reciprocal changes in the inferior leads, okay? So that's an LAD occlusion. Let's go to the next EKG. And this is a good example of something that I wanted to talk about how STEMIs progress, okay? So you'll notice that the rate is irregular in this rhythm. This is actually AFib. So this patient is in atrial fibrillation, okay? And if you look for the ST segments, you're going to see wildly elevated ST segments in V2, and then really V3, V4, and somewhat in V5. So this is predominantly ST elevation in the anterior leads, V3 and V4. So anterior STEMI. And this is really what I wanted to use this EKG as an example. There's my anterior myocardium. As an example of how we would expect for the ST segments to change over time, okay? So initially, this is kind of the flow of ST segment changes with time, right? So we have our baseline normal EKG, which is like this, right? Normally you have a P wave, QRS, and a T wave. That's our baseline, okay? Within, say, 30 minutes to hours of that ischemic event, before the ST segment can really rise with that full transmural ischemia or infarction, right? It's got to get there. It's got to take time. You're going to see something called hyperacute T waves. Okay? So what that's going to look like is you're going to have your P wave, your QRS, and then your ST segment is not going to be flat. It's going to become kind of hyperacute. Hyperacute, essentially, the area under the curve of the T wave is increased. You have an increased area under the curve. It's going to be bulky, right? And this is a STEMI equivalent. This is early onset, right? We're not even there, the ST segment can rise. But you can see this ST segment that's usually nice and flat is starting to kind of bulk up. It's starting to bulk up, so it's called a hyperacute T wave, okay? Then within a few more hours, you're going to get ST segment elevation, which is what we know, P wave, QRS, ST segment elevation, right? So that's going to be maybe 2 hours later, you're going to start really feeling that chest pain. Some people it's silent, but regardless, you're going to be really feeling that chest pain. And as the ST segment elevation, as the myocardial infarction progresses, a couple things you can expect to change. So I just want to talk about the changes that you're going to expect to see. If the myocardial infarction is bad enough, you're going to see it progress to a decrease in the QRS amplitude. Right? So you're going to see a decrease in the QRS amplitude because if the cells are dead or dying, they're not going to be able to conduct that signal as well. And so the amplitude, the positive amplitude, is not going to be as great. So you're going to have a decrease in the QRS amplitude or a decrease in the R wave, right? And there's positive forces, right? Then as time goes on, obviously, you're going to see that ST segment is going to get back to the baseline, but you might see some chronic T wave inversions, right? So you might see some T wave inversions as that ST segment is approaching back to baseline. You might see some T wave inversions. And then finally, as things resolve, you are going to develop some degree, not always, depending on if we saved the myocardium or not by going to the cath lab, pathological Q waves. And pathological Q waves are a chronic finding in someone that's had a previous ST elevation, myocardial infarction, where they have their P wave, and then whenever they go to create a QRS complex, they have these deep Q waves, right? So this Q wave in red, that's a pathological Q wave, right? Usually pathological Q waves are maybe greater than 2 millimeters or greater than 25% of the QRS amplitude, right? That initial negative pathological Q wave deflection is essentially telling me that we're unable to conduct signal in that direction. It's going to initially deflect away from it because it's scarred, right? So those are kind of some of the progressions of the ST segments. And so let's correlate that to this EKG. We have anterior STEMI, and look, V4, we don't have many positive forces. If I look really closely in a V4, you can see these QRS complexes, they just go straight down. So we've already lost positive forces. This is a pretty bad STEMI, right? You look at V2 and V3, there is not a whole lot of positive forces that are heading in those anterior leads. I would say this person's STEMI you can kind of use that as a metric of how well is this region of the myocardium conducting signal, right? And helping initiate that squeeze, right? So those are just some aspects that you can take a look at someone's EKG. Let's take a look at the next one. This is another example where we have, if you look closely, ST segment elevation in V2, ST segment elevation in V3, then to a lesser degree, V4, V5. You can see we also have reciprocal ST segment depression in lead 3 and AVF. So maybe a little bit of high lateral involvement, which we can look for. If you look in AVL, you see a little bit of kind of a hyperacute T wave, right? We don't really see a ton of ST segment elevation, but you see a little bit of a bulky T wave where the area under the curve is higher than what we would expect. So here we kind of have a predominantly anterior STEMI, but it also looks like we've got some septal involvement with V2 and then a little bit of V1. So maybe anterior septal, maybe just a handful of lateral involvement, right? This is a left anterior descending occlusion because the LAD, remember, supplies the septum and this anterior and some of the diagonal branches to the lateral wall. And so we take a look at this and we see that the septum really doesn't have a lot of positive forces. So you're just trying to get a gauge of what part of the myocardium is working or not. So this is another example of an anterior, maybe a septal, maybe a little bit of lateral involvement. This is a LAD occlusion, right? Alrighty, let's see. This is a great example of somebody with a left dominant. So remember, left dominant means that the left circumflex supplies the posterior descending artery, right? So in that case, this is my left circumflex. And the left circumflex, remember we said, can wrap around, and also in 20% of the cases supply the posterior descending artery as it branches down the posterior wall. So let's take a look at this EKG. The left circumflex supplies the lateral aspect of the myocardium. So what do I see? I see some ST elevation in V5 and V6. So we've certainly got lateral. We've got inferior, lead 2, 3, and AVF. And we've got this ST depression in lead V2, which we said was maybe indicative of posterior STEMI, right? So if we look at the regions of the heart that are supplied, we said we've got inferior, we've got lateral, right? A little lateral over here, and then we've got posterior, right? So when we try to figure out what coronary artery this is a tricky one because this is a left circumflex occlusion.
And I just want to give you a quick tip on why we can say with somewhat confidence before this person goes to the cath lab that this is a left circumflex occlusion. So remember, the left circumflex is going to be lateral, in this case posterior, and inferior, right? Because honestly, that posterior descending artery can wrap all the way around and catch the inferior aspect of the myocardium as well, right? But the clue is in leads 2, 3, and AVF. Remember that we said in right coronary artery occlusions, we're going to see more ST segment elevation in lead 3. So when we see inferior, if it's an RCA occlusion, we're going to see ST segment elevation in lead 3 the most, because it's more on the right side, greater than leads 2 and AVF, right? However, the left circumflex is coming from the other side of the myocardium. So the left circumflex, we're not going to see lead 3 greater than lead 2. And in fact, you can look at it here and you can say that lead 2's ST segment elevation, here's my baseline, here's my ST segment elevation, that lead 2's ST segment elevation is actually greater than that of lead 3's. So when you compare the two of those, lead 3 is not greater than lead 2. In fact, lead 2 has the most ST segment elevation. So in this case, lead 2 is greater than AVF is greater than lead 3, right? Really focus on lead 2 being greater than 3. That tells me that if lead 2 is greater than 3, that the ST segment is being produced because the inferior aspect is more left inferior, and then it kind of tapers off, right? And that tells me that the left circumflex is driving that inferior myocardial involvement, right? Not the right coronary, because the right coronary would be approaching from the other side. So that's a good example of a left dominant circumflex or left dominant heart, okay? So that's why we see this kind of, what we would call, I would almost call this an inferoapical STEMI, right? Because it's in the inferior, but it's also kind of on that lateral apical surface, okay? So let's see. We've got one more here. It's another example of a left circumflex occlusion. Same principle. Let's look here. We've got lateral ST segment elevation, right, in V4, 5, V6. And we've got inferior, 2, 3, and AVF. So right now we have an inferior plus lateral STEMI. Okay. Well, inferior lateral STEMI could be right coronary artery. We look and see that we've got reciprocal ST segment depression and AVL is depressed, even to a lesser degree, lead 1. So we've got reciprocal ST segment depression in those leads. But I want to determine, is this left circumflex right coronary artery, right? And why does it matter if we want to just clinically correlate left circumflex versus right coronary artery anatomy? Before we do that on this EKG, let's take a look at our heart. And let's look at the right coronary. If the right coronary artery is occluded, we're going to see dysfunction in the RV. We're going to see dysfunction in the AV node, right? So right ventricular dysfunction, we're going to get symptoms that are correlated with right-sided heart failure, right? You're going to see potentially lower extremity edema. They're not going to be responsive to certain treatments. And say if you tank their preload because they've got RV dysfunction, so you give them nitrates, vasodilators because they've got this chest pain, you give them vasodilators and you tank their pressure, throw them into cardiogenic shock because they are preload dependent if you have an RCA occlusion with RV dysfunction. On the other hand, if the left circumflex gets occluded, right, this is a little bit more of that left ventricle. So if the LV dysfunction occurs, you might see someone that comes in with florid congestive heart failure, right? Because if the LV is not pumping effectively because the left circumflex is occluded, they might have cardiogenic pulmonary edema, right? So that is why clinically this matters, the treatment of these two in terms of keeping them palliative, like trying to just keep them alive so we can go to the cath lab, is going to be very different. So that's why it is important to understand how to differentiate the two, at least so that whenever you understand, are my treatments working or not, how are they responding? So remember, left circumflex versus RCA, you can look at how leads 2, 3, and AVF relate to each other, right? RCA occlusions, lead 3 should be the dominant ST elevation, and left circumflex, lead 2, right? Because left circumflex is going to be more on this side, and right coronary artery is going to affect more on that side. Let's take a look and compare them, and you can see here that there is no like massive difference in these ST segments, right? So I don't see a predominant lead 3 compared to the rest. So just remember, if lead 3 is not incredibly dominant, consider left circumflex, right? Sometimes left circumflex, it's not even that lead 2 is dominant. In this case, it's more that lead 2 ST segment elevation is equal to that of lead 3. So big takeaways from today's lecture that I want you to remember. I want you to understand the coronary artery anatomy, how it functions in terms of its relationship from the epi and endocardium. I want you to understand how the progression of atherosclerotic disease contributes to chronic ischemic heart disease. Also, don't forget that that subendocardial region can be injured not just by a focal event, but also by a diffuse pattern of subendocardial ischemia from anemia or a rapid arrhythmia. And then also remember the focal findings of ST segment changes on the EKG. So I hope this was a great introduction. I hope you enjoyed it. And if you do find some value in this, the best way to support my channel is just to subscribe and to like these videos and to comment and interact. My goal is to build a community, and I hope that you guys enjoy being a part of the community. So thanks so much for watching. We'll see you on the next EKG lecture. Have a great day.